Now we are going to begin with pathology. So in pathology, we are going to have four topics: cell injury, inflammation, neoplasia, and aging. So first one is cell injury. So cell injury begins with growth adaptations. So whenever there's any kind of change in stress, either the stress may be increased or decreased. So what happens is first it begins with cellular adaptations. So what are the main kinds of cellular adaptations? You can see here clearly. First one is hypertrophy, next one is hyperplasia. Let us see the meaning also. So very simple, hypertrophy means increase in cell size. Plasia, you can see hyperplasia. Plasia means increase in cellular number. Atrophy means decrease in both number and size of cells. And metaplasia is change in new type of cell, and dysplasia is a precancerous cell. Of course, we are going to see even the examples in more detailed way. So this is a beautiful diagram to understand this concept. So first you can see these are the normal cells, and these normal cells can either be reversible or irreversible. How they are going to undergo adaptations is first you can see this is the diagram of hyperplasia where the cell number is increased, and this is hypertrophy. The number is same but the cell size is increased, and atrophy you can see the number is decreased and also the size of the cell is decreased. So if these three kinds of cells, they're not able to adapt to the stress because the stress is more than the expected, then this cell now will convert into irreversible injury, that is either necrosis or apoptosis. So this is where there's severe stress or injury which can't be bearable by this cell, so that will convert into irreversible injury, that is necrosis or apoptosis. And there is also another type of reversible cell injury, that is change in cell structure and change in cell type. So if the structure of the cell changes, like you can see these are the dysplastic cells which are precancerous cells, and if change in the cell type, like in metaplasia example you can take Barrett esophagus, where actually in the esophagus it is lined by squamous cells, and our stomach is lined by columnar cells. So if this esophagus lower side is replaced by columnar cells, then that is called as metaplasia. So finally you have neoplasia, that is where this dysplasia cells and metaplasia cells both have a chance to undergo irreversible cell injury, and finally that will convert into neoplasia. So now let us see the examples for each of this cell type. So first thing is cellular adaptations can be physiological or pathological. If it is physiological, it is you can see reversible. If it is physiological, reversible. Example is uterine enlargement during pregnancy. And the pathological one is myocardial hypertrophy, which is secondary to systemic hypertension. So generally hypertrophy is pathological, but if this this hypertrophy, if it is excessive or persistent for longer time, then the cell is not able to adapt to the situation, so it will undergo cellular injury. So in that cellular injury there will be left ventricular hypertrophy. So now this left ventricular hypertrophy will lead to myocardial injury because the cell is unable to bear this kind of exceeded stress. So now this left ventricular hypertrophy will convert into myocardial injury, and finally that will lead to heart failure. So this is one kind of example where growth adaptations finally converted into cellular injury. So this left ventricular hypertrophy is growth adaptation, and this myocardial injury is cellular injury where our cell is unable to bear the extra stress. So now let us see the examples of hypertrophy. Of course we are discussing about cardiac cells, so cardiac hypertrophy. And next coming to hyperplasia, here the physiological example is not physiological, pathological. Pathological example is endometrial hyperplasia in female. But one thing you need to remember, the exception, very important exception, is benign prostatic hyperplasia in male, because this benign prostatic hyperplasia in male can't convert into cancer, but this endometrial hyperplasia have a potential to convert into cancer. So that is very important in hyperplasia examples. Next coming to atrophy. In atrophy the size of the cell is decreased because of ubiquitin proteasome pathway and also autophagy process, but the number of cells are decreased by apoptosis. Of course we'll also discuss about apoptosis in next videos. So, and also loss of blood supply, loss of hormonal stimulation, poor nutrition, all this also will lead to atrophy. So next coming to metaplasia, already I explained about Barrett esophagus, and the next example is tobacco smoke. In tobacco smoke, the problem is the respiratory ciliated columnar epithelium is usually replaced by stratified squamous epithelium. So this may also progress to dysplasia. Either Barrett esophagus or stratified this tobacco smoke disease, both can progress to dysplasia, that is precancerous cell. So this precancerous cell can next transform into malignant cells. So if it is malignant, it will lead to cancer. So example is Barrett esophagus can become esophageal adenocarcinoma in future, and metaplasia of connective tissue like myositis ossificans is an example, and also keratomalacia is also example for metaplasia. So finally, dysplasia, here the cells are having the feature of pleomorphism. What is pleomorphism? That is this loss of uniformity in cell size and shape. So the size and the shape of the cell is not uniform, that is pleomorphism. So there's also loss of tissue orientation, and there's increase in nuclear to cytoplasmic ratio. So important things which we need to see here is that dysplasia is reversible, metaplasia is reversible. So both of these are reversible. Only this is the important thing, because in Barrett esophagus that can be reversible, and even dysplasia can be reversible. But once if you get neoplasia, it is irreversible. So both dysplasia and metaplasia, which are reversible, have a chance to convert into neoplasia when there is lot of irritation or lot of stress, chronic stress, and that neoplasia cannot be irreversible. So now let us come to cell injury. So cell injury is divided into reversible cell injury and irreversible cell injury. So with this diagram, we can now understand the reversible and irreversible cell injury. So this is a normal cell, and this is a reversible cell injury. The hallmark here is this hypoxia, that is decreased oxygen in the tissue. So as the oxygen is low, oxidative phosphorylation process in the mitochondria will be low, and finally the ATP will drop. So as the ATP will drop, you know that the calcium and sodium potassium pump start dysfunctioning, so that the calcium and sodium potassium pumps will be gone, and finally the cell will undergo the process of swelling. So this diagram shows clearly the cellular swelling here, and also you can see the membrane blebbing here, because lot of fluid has come out into the cell, so that is leading to blebbing. And here you can see the nuclear chromatin clumping, and even the ribosomes will get detached. Actually this is seen in irreversible cell injury. First, in reversible cell injury, the main thing is cellular swelling, and there's also ribosomal and polysomal detachment, so that the protein synthesis will decrease, and the plasma membrane will change, that will lead to blebbing. And there's also nuclear change where chromatin is clumping, and there's rapid loss of function, that is myocardial cells are non-contractile after 1 to 2 minutes of ischemia, and the myelin figures are aggregating, that is nothing but the peroxidized lipids. So now in irreversible cell injury, we can see there is a breakdown of cell membrane. So main thing you should see, the hallmark of reversible cell injury is swelling, and the irreversible cell injury hallmark is membrane damage. So as the membrane will get damaged, not only the cell membrane, even the mitochondrial membrane, endoplasmic reticular membrane, everything will get damaged. So the first thing is breakdown of plasma membrane, so that troponin like substances may leak out of the cell, and that will lead to activation of different degradative enzymes. And finally the mitochondrial membrane will damage, so that will lead to loss of electron transport chain, and of course decrease ATP. Finally there is rupture of lysosomes, that will lead to autolysis. And there is also nuclear degradation, especially by three process. Pycnosis is where the nucleus will come nearby. Karyorrhexis is the process by which the nuclear will undergo fragmentation process by endonuclease, and karyolysis is the process where nucleus will undergo dissolution. And finally there are amorphous densities and inclusions in the mitochondria. So this is the process of reversible and irreversible cell injury. And finally the cell will undergo cell death. So cell death is divided into necrosis and apoptosis. Necrosis is like murder process, apoptosis is like suicide process. So first one is reversible, irreversible. So this is a cell injury. Now let us discuss about apoptosis. So apoptosis is the process, it's actually the meaning of apoptosis is falling off leaves. So actually in this process what happens is the cell will, the cell, especially the nucleus will shrink, and next the cell will shrink, and the cell will fall off as if like a leaf falling from a tree, especially in autumn season. So actually this process is ATP dependent process. This is also called programmed cell death, because there's some program which is going on inside the cell. So there are two pathways, that is the intrinsic pathway, that is which is going on in the mitochondria, and extrinsic pathway, which is also called death receptor pathway. So intrinsic pathway is in the mitochondria because this apoptosis process actually takes place inside the mitochondria. The main concept background which you need to understand here is, first there's a watchman called BCL2, and this watchman always keeps a look at mitochondria, especially cytochrome C which is inside it. Why is because if cytochrome C leaks out of mitochondria, it will activate caspase. So if it activate caspase, then caspase can activate in turn endonuclease and also proteasome. So if this activation of endonuclease, then there is DNA destruction, and if there is activation of proteasome, that will lead to destruction of cytoskeleton. You can see the cytoskeleton is destructing here because of activation of caspase and the nuclear fragmentation. So finally there's a cytoplasmic bleb which forms, and this bleb comes out as an apoptotic body, and this apoptotic body have some macrophage cell receptors which bind with the macrophage, and finally macrophage will engulf it. So this is how apoptosis generally occurs. So now let us see the intrinsic pathway. Important things in intrinsic pathway are backs and back. What are this? These two are bad for survival because they are pro-apoptotic. Backs and back they improve the apoptosis process. I mean, they activate the cytochrome C to come out, they activate caspase, in turn activate endonuclease, protease, and finally leading to cell apoptosis. So backs and back are activating apoptosis, whereas BCL2 and BCLXL, so whatever the BCL, it will inhibit the apoptosis. So BCL is like a watchman who is inhibiting the apoptosis. Very important point. And one more thing which you need to see is there's a BCL2 overexpression in one tumor which is very important, that is follicular lymphoma. In follicular lymphoma there's translocation between 14 and 18 chromosome, so there's overexpression of BCL2. You can understand if there's more BCL2 there will be no apoptosis, so that this cancer can never die. So it's the technique of the cancer to express more BCL2 so it can never undergo apoptosis. So there's decreased caspase activation, and this is tumorigenesis. Now coming to extrinsic pathway. Extrinsic pathway is where we have two things. One is fast ligand and fast ligand, and it's fast receptor. So actually here what we do is there's a fast receptor, for that the fast ligand binds, and finally it will activate the caspase inside the cell, and the same process undergoes finally apoptosis. Whereas there's one more thing called perforin and granzyme. Actually perforin, the name itself you can see, it will perforate the membrane of the bacteria or the cell which it wants to kill. And next the granzyme enters inside the cell, and it also activates the caspase, and in turn again it activates the endonuclease, and also again it can activate the protease. So finally the cytoskeleton will be gone, the DNA will be fragmented, and finally the same process again, it will give this apoptotic body to macrophage, and macrophage will finish it, like it will eat it away. So now coming to another disease called autoimmune lymphoproliferative syndrome. So in this disease it is a problem in fast and fast ligand interaction. So if there is no interaction, that will lead to increase in number of self-reactant. It's an autoimmune disease, right? So self-reacting lymphocytes will be more, and this will present with lymphadenopathy, hepatosplenomegaly, and also autoimmune cytopenias. So this is all about apoptosis. Now let us see about necrosis. As I already said, necrosis is nothing but it's a exogenous injury, like it's a murder process where first thing is plasma membrane got damaged, and next cell will undergo enzymatic degradation, protein denaturation, and finally all the intracellular components will leak, and that will lead to local inflammatory reaction, but that is not apoptosis. One important key feature between necrosis, you need to compare between necrosis and apoptosis is necrosis is followed by acute inflammation. Very important. Apoptosis will never involve acute inflammation. Okay, so there are different types of necrosis which you can see. The first one is coagulative, next liquefactive, caseous, fat, fibrinoid, gangrenous. I'll explain each of these along with if it is having any diagram, okay, along with the diagram, and we'll understand every point. So one more thing I need to say. First we have discussed about growth adaptations. What are growth adaptations? Hypertrophy, hyperplasia, atrophy, all this, okay. So if the stress is more, then the cell will go to cell injury. What is cell injury? Reversible cell injury, irreversible cell injury. And the hallmark of reversible cell injury is cellular swelling, and the hallmark of irreversible cell injury is membrane damage. And the hallmark of cell death, in cell death we have necrosis and apoptosis, and the hallmark of cell death is loss of nucleus. So whenever you have necrosis you will lose your nucleus, so this is very important. Now let us see about coagulative necrosis. So the first diagram A here shows the coagulative necrosis. So actually in coagulative necrosis, the name itself you can see it's some like coagulative, something coagulation. So there's seen mainly in ischemia, infarcts in tissues. But very important thing is coagulative necrosis can be never seen in brain. It can be seen in every tissue except brain. But in brain you can see liquefactive necrosis. Okay, I'll discuss it next. So remember, in brain there is no coagulative necrosis. It is due to ischemia, infarction. There's proteolysis of enzymes, but the cellular shape, architecture, everything appears normal. The nuclei disappear because it is necrosis, and there's increased cytoplasmic binding of eosin stain. Like it will appear more pinkish, you can see here. So this is coagulative necrosis. Now moving on to liquefactive. In the name itself you can see liquid like. So you can see some liquid type. So this is liquefactive. It is seen especially in brain and some bacterial abscess kind, and liquefactive is also seen in pancreas. So here the problem is because the neutrophils release mainly lysosomal enzymes, and that enzymes digest the tissue and form liquid like structure. So the histology is, you can see the cellular debris with macrophages. In the late stages you will see some spaces, cavitation. All the debris will be sometimes accumulated with bacterial infection. Next, let us move to caseous. You can see the caseous necrosis. It's something like cheese-like necrosis, and this necrosis is mainly seen in TB, fungi, histoplasma, capsulatum, nocardia kind of organisms. The main thing is because the macrophage wall off the infecting microorganism, and that will form this kind of debris, macrophage. Okay. And here there are fragmented cells, debris, lymphocytes, macrophages. You can see it's like a granuloma. There's also granuloma formation here. Now coming to fat necrosis. So this shows the fat necrosis. In the name itself you can see fat. So it will be mostly in fatty tissues like breast, pancreas. And the important thing, in acute pancreatitis there is saponification. What is saponification? Calcium plus fat is saponification. Okay. And here you can see mainly damage of pancreas by lipase, which break down triglycerides and liberate fatty acids. Next, coming to outline of dead fat cells without peripheral nuclei. Here also no nuclei, and this is mainly very dark, you can see in H&E staining. Now coming to fibrinoid. Fibrinoid necrosis is just like when you have hypertension or vasculitis, that the blood vessel will break down and all the contents will come out and it appears pink like this. This is fibrinoid necrosis. It is seen in immune vascular reactions, hypertensive emergency, preeclampsia. Here the immune complex may also deposit. So it is a type 3 hypersensitivity reaction. All the plasma will leak out, and the vessel walls contain eosinophilic layer of proteinaceous material. You can see the protein material here. Now coming to gangrene, it is mostly seen in diabetes foot, right? Also on the end of the fingers you can see. This is mainly affecting distal extremity and GI tract after chronic ischemia. It is divided into dry and wet type. If it is dry, you can see this is ischemia dry one. Wet will be somewhat watery. So actually gangrenous involve two types of necrosis, coagulative plus liquefactive. Very important. Coagulative and liquefactive together form gangrenous necrosis. Now let us move on to ischemia. So in the name itself, you know what is ischemia? It is low blood supply. So if there's low blood supply, that is low, especially to the artery, that is low arterial perfusion, that is atherosclerosis. If there's low blood supply, low outflow, like low venous drainage, that will lead to testicular torsion. You know, testicular torsion will cause red infarct. And but GRE syndrome, where there's no outflow, only income is there, there's no outcome, that is the vein is unable to drain the blood. And in shock, you know, completely there's low blood supply. So the regions which are most vulnerable to hypoxia and ischemia are brain, heart, kidney, liver and colon. And you need to see what areas. In brain, ACA, MCA, PCA. Boundary areas are more vulnerable, and in heart, subendocardium of left ventricle. In the diagram you can see this yellow lines, they represent the subendochondrial infarction. And in kidney, especially the straight segment of proximal tubule medulla and the thick ascending limb of medulla are most vulnerable. In the liver, the area around central vein, you know, in zone 3. In colon, splenic flexure, that is Griffith point, and rectosigmoid junction, that is Sudeck point. These are most vulnerable. So the watershed areas are the zones where they receive the blood supply from most distal branches with limited collateral vascularity. So these are susceptible mostly to ischemia from hypoperfusion. We know this. And very important thing is neurons are most vulnerable to hypoxic conditions. Now let us see the infarcts. Infarcts are divided into red infarcts and pale infarcts. So here the A represents the red infarct. You can see how red it is, and pale you can see in kidney, this part, this wedge-shaped part, you can see how pale it is. So one thing you need to know that red infarcts occur in venous occlusions and tissues with multiple blood supply. Example, you can take in liver, lung, intestine, testes. Here this red infarct, because already the blood is blocked, but the blood, the outflow is blood and the blood is coming inside and accumulating and forming red color tissue. This is also with reperfusion. So reperfusion injuries will lead to free radicals, very important. And pale infarct, you can see it is seen mainly in solid organs which have end artery supply, like only one artery supply. So in that case you can say heart and kidney which have only end artery supply, so they get the pale infarct. Now coming to free radical injury. So what are actually free radicals? Free radicals are the ones which have one unpaired electron in their outer membrane, right? So they damage our cells mainly by peroxidation of lipids and by modifying the proteins and DNA. So this process, these free radicals are generated because of either radiation exposure in cancer or because of some drugs and also some redox reactions, nitric oxide, metals especially like copper, iron, infenton reaction, even WBCs, oxidative burst, everything. So the main thing which you need to know in the free radical generation is, first the oxygen is converted into superoxide by NADH, okay, and this superoxide is now converted into hydrogen peroxide by superoxide dismutase, and this hydrogen peroxide now can be converted into hydroxide, and this hydroxide will finally convert into HOCl or either into water. So this process is very important, where free radicals, all these are free radicals: superoxide, hydrogen peroxide, hydroxide, and the most dangerous free radical is hydroxide, which is very important to remember. So here the examples which you need to take which are leading to this problem, free radical problem, is with enzymes like catalase enzymes, superoxide dismutase, glutathione peroxidase, antioxidants, and certain metal carrier proteins. All this can eliminate the free radicals, very important. These enzymes, these antioxidants, this carrier protein have a capacity to eliminate the free radicals. And there are some examples like you can take oxygen toxicity by bronchopulmonary dysplasia, reperfusion injury after thrombolytic therapy, and some drugs like acetaminophen toxicity, carbon tetrachloride in dry cleaning industry. Actually, this carbon tetrachloride will convert into CCl3, and this CCl3 is a free radical which is causing fatty liver. So be careful, women who are wearing dry clean sarees, because maybe your CCl4 may convert into CCl3 free radical and you may get the fatty liver. So just a joke to remember this. And even some metal storage diseases like hemochromatosis, Wilson disease, also there's a free radical injury problem. Now let us move to ionizing radiation toxicity. So actually the problem with ionizing radiation is it causes many free radicals, that is the outer portion of electron is having unpaired electrons. So because of that, more free radicals are forming and the DNA is getting breaked, and there's also cellular damage both directly and indirectly. So there's mainly localized inflammation of that specific tissue which got affected by radiation, and it will also undergo fibrosis, and there's also neoplasia. Neoplasia, like you can get either leukemia or thyroid cancer mainly because of this radiation. And there's a syndrome called acute radiation syndrome. This is developing after sudden whole body exposure to high dose of radiation. So the features will be nausea, vomiting, diarrhea, hair loss, erythema, cytopenias, like several cells may drop, headache, altered mental stages. So we give stem cells rapidly to this patient so that we can regenerate all the lost cells, like we give skin, bone marrow, GI tract, gonads, because these are most susceptible to radiation injury. So radiotherapy also damages the cancer cells more than healthy cells because cancer cells have dysfunctional DNA, right? So that's why we actually prefer radiation to cancer people, so that their DNA will easily break, so that we think cancer may drop. But if this radiation also hits the normal cells, that will be a main problem, because even that normal DNA will break now. So now coming to types of calcification. So now coming to, as I said, calcification, there is calcium deposit which appears deeply basophilic. You can see here this basophilic, how blue this is on HND staining. So actually it is dystrophic and metastatic. Dystrophic, in the name itself you can see dystrophic. Actually it's not the normal place where the calcium should deposit. It is depositing in abnormal tissues and diseased tissues. So it is actually localized. For example, in lung, pericardium, it can go and deposit, or it is associated with some granulomatous infection, liquefactive necrosis, fat necrosis, thrombi, all these conditions. You can see rubella, Crest syndrome. What is Crest syndrome? It is seen actually in scleroderma patients, where C stands for calcium deposition, R for Renault phenomena, E for esophageal dysmotility, and S is for sclerodactyl, and T for telangiectasia. So this is a Crest syndrome. And there are also atherosclerotic plaque which can become calcified. So it's nothing but in the diseased tissue the calcium is going and accumulating. So it is mainly seen secondary to any injury or necrosis. There's some injury, necrosis, and next this calcium will go and attach there. This saponification is also something like that, where in fat necrosis, calcium and fat are mixing together, that is saponification. But this serum calcium levels are normal in dystrophic calcification patients. Whereas coming to metastatic calcification, it is seen in normal tissues, but there's widespread calcification. It is seen mainly in interstitium of kidney, lung, gastric mucosa, in nephrocalcinosis of collecting duct, renal failure, or this patient. Actually, here the problem is because of hypercalcemia. Already there is lot of serum calcium. As there is lot of serum calcium, now it is not understanding where to go, and it is going to different organs and going and accumulating. That's why the name is metastatic, because it's going to different organs. Very important thing you need to know: dystrophic calcification, serum calcium is normal, but the calcium itself gone crazy and going in accumulating in diseased tissues. But metastatic classification, the problem is that this calcium is going already high in the blood, and now it is going to different organs because it is not understanding where to go, so it is accumulating. So it is usually abnormal. That is, a serum calcium levels are abnormal. The last one will end with lipofuscin, this first part. So lipofuscin is actually yellow brown wear and tear pigment. It is seen in aging, like in old people we see this. It is composed of lipids mainly, and also phospholipids with some proteins. It is derived by lipid peroxidation of mainly polyunsaturated lipids. Okay. And autopsy, especially if you take autopsy of older people, then you will see this lipofuscin deposits in different organs like heart, colon, liver, kidney, eye, and other organs. So by this we complete part 1 of pathology.